I want you to imagine, just for a second, walking into a modern intensive care unit or maybe a high-stakes trauma bay.
Right, a very intense environment.
Exactly. You look around and you are immediately surrounded by, millions of dollars of cutting-edge technology. I mean, there are high-definition digital screens everywhere, ventilators making these precise computerized adjustments, and IV pumps just blinking with all these micro-infusions.
It is incredibly high-tech.
Yeah. And yet, right there amidst all of that space-age tech sitting literally on the floor at the foot of the bed
Yeah.
is a plastic box bubbling with water.
It is such a profound contrast, really. I mean, you have this incredibly sophisticated digital environment all around you, and then you have this totally analog device just sitting there.
Just a plastic box.
Right, just relying on basic fluid dynamics to keep a patient's lung from collapsing.
And that plastic box is doing arguably one of the most critical, life-saving jobs in the entire room. So today we are taking a deep dive into the 150-year-old physics behind the chest tube.
It is a fascinating topic.
We're looking at how it works, the fatal historical mistakes that led to its creation, and why trying to help the machine can sometimes be downright deadly.
Okay, let's unpack this. To understand what this bubbling box is actually doing, we first have to understand the space it's tapping into.
Yeah, we really need to look at the physics of what we call the pleural space.
Oh, the pleural space.
Exactly. This is the potential cavity between the outside of the lung and the inside of the chest wall. And, normally this isn't some gaping cavern.
Right.
It holds just a very, very thin film of lubricating fluid. And crucially, it exists at a negative pressure.
Okay, negative pressure. How negative are we talking?
We're talking about roughly -5 centimeters of water pressure at rest.
Yeah.
And that pressure actually drops even further when you take a breath in.
So it's essentially a vacuum, right?
But pretty much, yeah.
Yeah.
See, the lung naturally wants to recoil. It wants to shrink down, sort of like a deflating balloon.
Oh, I see. So that negative pressure in the pleural space acts as this constant suction force. It keeps the lung's elastic recoil in check and holds it pulled open, expanded tightly against the inside of the chest wall.
I always like to conceptualize this for you, the listener, like two wet panes of glass pressed together.
Oh, that's a great analogy.
Yeah, if you take two wet panes of glass, you can slide them around against each other pretty easily.
Right.
That's your lung expanding and contracting against the chest wall. But try to pull those glass panes directly apart, like straight away from each other, and the suction is incredibly strong.
You just can't do it.
Exactly. But if you get even a tiny bubble of air or maybe a little bit of extra fluid between those panes of glass, that seal is completely broken.
And that's exactly what happens in the body. The moment that seal breaks, whether it's from a punctured lung leaking air or a bleeding vessel, an infection, maybe fluid from a tumor, the pressure in that space rises right back toward atmospheric pressure.
And without that vacuum,
Without that negative pressure holding it open, the lung simply collapses, just folds in on itself.
wow.
So the chest tube's entire job is to remove whatever broke that seal and reestablish the vacuum. And the standard unit actually does this using 3 distinct chambers in that little plastic box on the floor.
Right. Let's picture the physical layout before we get into the wild history here.
Yeah.
The first section the fluid hits is simply the collection chamber, I believe.
Correct. It's really just a reservoir.
So if a patient is bleeding into their chest or draining pus or something, the tube just carries it out of the body and deposits it right into this first compartment.
Yeah, that way clinicians can measure the exact volume and, actually see what it looks like.
But the real magic, the really interesting part, happens in the second and third chambers. And to understand why those chambers were even invented in the first place, we have to look at the disastrous ways humans tried to fix a collapsed lung in the past.
Oh, absolutely. I mean, the instinct to drain something bad out the body is ancient. Well, Hippocrates actually described treating empyema, which is a collection of pus in that chest cavity, by basically slicing the chest open, packing the wound open, and sometimes even using cautery just to let the pus drain out.
Wait. If the whole point is this delicate vacuum, doesn't slicing the chest open completely ruin that?
It does, completely.
An open hole might let the pus out, but it destroys any remaining negative pressure gradient. You've essentially created an open pneumothorax, what we'd call like a sucking chest wound today.
Exactly. And that exact flaw became tragically apparent much later during the 1918 influenza pandemic and World War I.
Oh, right.
You had this massive, massive wave of young soldiers developing secondary bacterial empyema from the flu. Just imagine these huge temporary military hospitals, wards completely overflowing with young men struggling to breathe.
That sounds horrific.
It was. And the physicians at the time, they initially treated it the old Hippocratic way with early open surgical drainage.
And the mortality rate was just staggering, right? Because opening the chest early, before the infection had a chance to, wall itself off with scar tissue, meant they were taking a contained problem and basically converting it into an open chest wound.
Yes, the treatment was literally killing 30 to 70% of these soldiers, often way faster than the actual infection was killing them.
Wow, up to 70%.
The U.S. Army had to intervene. They convened what was called the Empyema Commission, led by these prominent physicians like Everett Graham and Rufus Cole.
And they actually figured it out.
They did. They investigated these deaths in the camps and realized the fundamental physics error they were making. So they recommended an immediate switch to a closed underwater seal drainage system.
A closed system.
Right. And if we connect this to the bigger picture, this is one of the clearest cases in medical history of a controlled clinical observation completely rewriting surgical dogma almost overnight.
That is amazing.
They proved that to save these patients, the drainage system had to be a closed one-way street.
Which brings us perfectly to the second chamber of our plastic box, the water seal. Because, you have to figure out how to let air and fluid out of a patient's chest without letting atmospheric air rush back in.
Exactly. It's a tricky engineering problem.
Right. And the solution is this really ingenious 19th century mechanical fix popularized by Gotthard Bülow. They actually still call it Bülow drainage in parts of Europe, I think.
They do, yeah.
And also a British obstetrician named W.S. Playfair.
The beauty of the water seal is just its utter simplicity. The drainage tubing coming out of the patient's collection chamber routes directly into this second chamber, and the end of that tube is submerged exactly 2 centimeters underwater.
Just 2 centimeters. That's it.
That's it. That small water column creates a perfect mechanical check valve.
Okay, so how does that work in practice?
Well, when the patient exhales, the pressure in their chest naturally rises. This pushes any trapped air or fluid down the tube. It forces its way out of the submerged tube, bubbles up through those 2 centimeters of water, and just escapes into the atmosphere.
Here's where it gets really interesting, though. When the patient inhales, the pressure in their chest drops, right?
Right, it drops.
It creates a vacuum, trying to suck air back in. The water in the box is drawn up into the tube slightly, but the weight of that 2 centimeter barrier is just enough to prevent atmospheric air from being sucked all the way back up into the chest cavity.
Exactly. The air can get out, but it cannot get back in.
That is so elegant.
It is. And this water seal, it acts as this brilliant real-time diagnostic tool for the nurses and doctors. Clinicians use this primitive water column as a literal window into what's happening inside the patient's chest.
What are they looking for?
The most common visual cue is something called titling. If you have a patient breathing on their own, you will see the water level in that seal chamber rise slightly when they breathe in and fall when they breathe out.
So it literally looks like a gentle tide.
Yes, exactly like a tide. You are literally watching the pressure swings in their pleural cavity. You are watching their physiology happen in real time.
That is wild.
There is a fascinating caveat here, though. Oh.
Yeah, if a patient is on a mechanical ventilator, that titling pattern reverses.
Wait, why would it reverse?
Because a ventilator uses positive pressure. It forcefully pushes air into the lungs during inspiration, so the water level would actually go down on inspiration and up on expiration.
Oh, that makes total sense because the pressure dynamics are flipped.
Right. But in either case, if that titling suddenly stops completely, it tells the clinician something has changed. Either the lung has fully re-expanded and healed right up against the chest wall, or the tube is blocked.
And we will definitely get to why a blocked tube is terrifying in just a minute. But sticking with the visual clues for a second, what about the bubbles? If a patient has an active air leak, like a pneumothorax, you'll see that escaping air bubbling up through the water seal, right?
You will, yes. And modern units, like the Atrium or Plurivac systems, they take this a step further. They have an air leak meter right next to the water seal.
How does that work?
It's usually graded on a visual scale, number 1 to 7. This allows the clinical team to actually quantify the leak. Oh, so they aren't just guessing how bad it is.
Exactly. They can look and say, is it a tiny grade 1 leak that only bubbles when the patient forcefully coughs? Or is it a massive, continuous grade 7 leak that's just bubbling away even when they're resting quietly in bed?
And tracking that number over days is how they decide if a patient is healing.
Yes. If a post-surgical air leak persists past, say, 4 to 7 days without that bubbling slowing down, the team might stop waiting.
What do they do then?
They might intervene surgically with something called a pleurodesis. This is a procedure where they deliberately introduce an irritant to scar that pleural space shut. They basically glue the lung to the chest wall so no more air can gather there.
Wow, just glue it shut. So the water seal really does dictate the whole treatment path. Though we should also mention that a bubbling box isn't the only way to create this one-way street anymore, is it?
No, it's not. In 1965, an American surgeon named Henry Heimlich,
Wait, yes, the same Heimlich of the choking maneuver.
the very same Heimlich, he invented the Heimlich flutter valve.
So what is that?
He essentially replaced the bulky water bottle with a small rubber one-way sleeve. It looks kind of like a little rubber duck beak.
Oh,
It lets air push out, but it claps completely shut when air tries to suck back in.
that's brilliant. Suddenly, instead of being tethered to a bubbling box on the floor, patients could actually get up and walk around.
It was huge. It was heavily used for chest wounds during the Vietnam War, and it's still used today for ambulatory patients who need to be mobile.
Okay, so if bubbling means air is escaping the chest, let's just suck that air out as fast as possible, right?
Well,
Which brings us to the biggest misconception about the third chamber. We've covered the collection reservoir and the one-way water seal. Now let's talk about the suction control chamber.
right. Most of the time, simply allowing the fluid or air to escape by gravity isn't quite enough to re-expand a really badly collapsed lung. You need to actively pull the air out.
So you hook it up to a vacuum.
Yes, these systems are hooked up to wall suction, and the standard convention is to apply roughly -20 centimeters of water pressure to the chest.
And here is the massive misconception, especially among newer clinicians, right? You look at the wall behind the patient's bed, and there's this vacuum dial. The natural assumption is, well, if I turn that dial on the wall up to maximum, I am increasing the suction pulling on the patient's lung.
It's a very logical assumption, but the physics of these units are rigidly designed to prevent exactly that.
Wait, really? It prevents it.
Totally. The actual suction strength the patient experiences is determined entirely by how deep a specific tube sits in the water column of that third suction control chamber.
Ah.
It is physically fixed at that -20 centimeter mark by the depth of the water itself.
Okay, so it's like stomping on the gas pedal while your car is in neutral.
That is exactly what it's like.
You can crank that wall suction dial as high as you want, but if the box's water column is set to 20, the patient is only ever getting -20.
Precisely. You don't make the air pull out any faster at all.
All you do is violently boil off the water in the chamber through rapid evaporation.
Yes, you waste resources, you make the room incredibly loud with all this vigorous bubbling, and you force the nurses to constantly refill the evaporated water just to maintain the baseline suction level.
It's a classic example that more is better intuition just completely failing in the face of basic physics.
You really only need the wall suction turned up high enough to produce a very gentle, continuous bubbling in that third chamber. Anything beyond that is honestly theatrical, not therapeutic.
Theatrical, I like that. But, misunderstanding the suction dial wastes water, but misunderstanding how to physically maintain the tubing can literally kill a patient. Let's talk about the dangers of trying to help a sluggish chest tube.
Yes, this brings us to the highly debated historical practices of milking or stripping the chest tubes.
Milking the tubes.
Right. The intention was good, of course. Nobody wants a chest tube to clog with a blood clot because then it stops working. So nurses were taught for decades to aggressively squeeze and strip the rubber tubing with their bare hands, pinching it close to the patient and rolling their fingers forcefully down toward the box to force out any clots.
Right, but when you pinch and roll your fingers down that rubber tubing, you are physically forcing fluid out. But when you let go, the tubing violently expands back to its normal shape. And because it's a closed system, snapping back to shape creates a massive vacuum, pulling back toward the patient's chest.
The reality of what that stripping action does to the pressure inside the chest is genuinely alarming. Remember, our target therapeutic suction is a gentle -20.
Right.
When researchers actually measured the physics of stripping a tube, they found it can cause transient pressure spikes inside the pleural space of -100 to over -300 centimeters of water pressure.
-300.
Yes.
That is a massive, violent suction force just suddenly ripping at delicate lung tissue.
It's enough to literally shred the pleural tissue. And furthermore, that sudden violent pressure shift can actually provoke vaguely mediated heart arrhythmias.
How does that happen?
Well, the vagus nerve is like the body's main superhighway for the parasympathetic nervous system, and it helps regulate heart rate.
Right.
The severe pressure spike from stripping the tube shocks the vagus nerve, which can actually cause the heart to skip beats or slow down dangerously.
That's terrifying.
Because of this physiological trauma, and the fact that there's really no strong evidence stripping actually prevents clots any better than gentle observation, modern thoracic guidelines now widely discourage it.
Okay, so definitely don't strip the tube. But what about clamping it?
Clamping is another big one.
Right, because my instinct, if I'm, say, moving a patient down the hall to get a CT scan, or if the unit accidentally gets knocked over and disconnected, is to immediately clamp that tube shut tight so no outside air gets sucked into their chest.
What's fascinating here is that your instinct, while completely understandable, is entirely backward.
Wait, really?
And following it could be fatal.
Oh, wow.
Think back to the core reason the tube is there in the first place. It's an exhaust pipe. It's a one-way exit.
Right, to let air out.
If a patient has an active air, leak meaning air is continuously leaking out of a hole in their lung and into that chest cavity, that air is using the tube to escape. If you clamp the tube, you trap that newly leaking air inside the chest with nowhere to go.
Oh, I see. So with every single breath they take, more air leaks out of the lung into the cavity. And it just builds and builds.
The pressure builds incredibly rapidly. It compresses the injured lung, and eventually the pressure gets so high, it literally pushes the entire mediastinum, that's the heart, the trachea, the major blood vessels, over to the completely opposite side of the chest.
That sounds disastrous.
It is. It compresses the healthy lung and kinks the major blood vessels, which completely compromises the heart's ability to pump blood. This is called a tension pneumothorax. It is a genuine, immediate medical emergency.
So the ironclad rule is you never routinely clamp a draining chest tube, ever.
Never.
If the tube accidentally disconnects from the plastic box, you don't clamp it, you quickly reconnect it. And if the box itself is broken, you just submerge the open end of the patient's tube into a bottle of sterile water to immediately recreate that simple 2-centimeter water seal.
Exactly. Keeping the system open to let pressure out is paramount. Clamping is strictly reserved for very specific, tightly ordered circumstances by a physician, usually just to check for leaks right before the tube is permanently removed.
That makes total sense when you understand the physics.
Mm-hmm.
So we spent a lot of time on this century-and-a-half-old analog water-based technology, but this is the 21st century. Do we still actually need to rely on looking at bubbles in a plastic box?
We don't necessarily. The
Okay.
major alternative today is electronic digital drainage systems like the Topaz unit.
How are those different?
Well, instead of a nurse looking at a bubbling chamber and subjectively trying to decide, is that a grade 3 leak or a grade 4 leak, these digital units measure the exact flow of air mathematically.
Oh, so actual numbers.
Right, usually in milliliters per minute. They provide continuous, highly accurate numerical data on the pleural pressure.
I have to admit, though, considering how elegant and incredibly cheap the 150-year-old water seal is, I mean, it's basically just plastic and tap water. Is it really worth the massive hospital expense to digitize it?
It's a fair question. The main argument for digital systems is that they completely eliminate human subjectivity.
What do you mean?
Well, if one shift nurse says a leak is resolved and the night shift nurse says it's still bubbling slightly, that disagreement delays removing the tube.
Oh, I see.
Several thoracic surgery studies have found that digital systems provide such objective data that patients often get their tubes removed days earlier.
Really, days earlier.
Yes, which drastically reduces their hospital stay and significantly lowers the risk of hospital-acquired infections. So yes, the initial capital cost is much higher, but the downstream savings and the patient comfort really offset it.
And comfort is a major factor because the scope of who actually requires a chest tube is massive. We mentioned trauma victims earlier, like stab wounds, gunshot wounds, car accidents.
Right.
But it's also classically required for tall, thin young men who are prone to spontaneous pneumothoraces, where a small blister on the lung just pops out of nowhere.
That's right. Millions of patients also get them routinely after cardiac or thoracic surgeries just to drain post-operative bleeding. And notably, they became a huge topic during the COVID-19 pandemic.
Right, because of the ventilators.
Yes, exactly. Clinicians saw elevated rates of barotrauma, which is physical lung damage caused by high pressure and mechanically ventilated patients.
Because their lungs were so damaged by the virus.
Yeah, these patients had severe ARDS, or acute respiratory distress syndrome, which made their lungs incredibly stiff and inflamed. The ventilator pressure required to force oxygen into those stiff lungs was sometimes so high that it actually caused the lung tissue to tear,
Oh.
essentially popping the lung and necessitating emergency chest tubes.
It's incredible how versatile they are. So what does this all mean? If you, the listener, had to walk away with a mental cheat sheet for understanding that bubbling box on the floor, what are the core rules?
Let's do it.
Rule number 1. It is all about one-way traffic out of the chest. Air and fluid out, atmospheric air never back in.
Spot on. Rule number 2. If that gentle titling of the water stops, it is not automatically a celebratory moment. It might mean the lung has healed, sure, but it could also mean the tube is blocked by a clot, and you have to immediately figure out which it is.
Right. Rule number 3. Louder bubbling in the suction chamber does not mean stronger suction. The physical depth of the water sets the suction limit, not that vacuum dial on the wall.
And rule number 4, maybe the most important of all, never routinely clamp a draining chest tube. You risk turning a simple air leak into a deadly tension pneumothorax by trapping that pressure inside the body.
Those are fantastic takeaways. There is one final thought I want to leave you with, something to ponder that opens up a much larger question about modern medicine. The very definition of a chest tube is currently shifting. For decades, the standard was inserting these massive 36 to 40 French trauma tubes into patients.
Right.
And French is just a sizing scale where higher numbers mean a wider diameter. So a 40 French tube is essentially the width of a garden hose.
Which requires an incredibly painful, highly traumatic insertion procedure.
Exactly. But recent evidence shows that for simple pneumothoraces, doctors can often use an 8 French pigtail catheter.
Much smaller.
It is tiny, it's placed gently over a thin wire, it's vastly less painful, and it does the exact same physiologic job of draining air just as well.
That's a huge shift.
It really is. It makes you wonder, if we spent decades inflicting the pain of massive garden hose tubes on patients before realizing a tiny, delicate catheter appeased the physics just as effectively, how many other entrenched, painful medical procedures in our modern hospitals are currently drastically over-engineered for what the physics actually require?
That is a great point. We often assume the way things are done is the only way they can be done, until someone finally steps back and questions the fundamental mechanics of the problem.
It really makes you look differently at that simple plastic box bubbling on the floor of the ICU. It's not just a drain, it's a 150-year-old physics lesson hiding in plain sight.